time talking to Judy, that's the instructor that's going to be coming. I had to get a hold of ATI in Kansas. So I talked to the ATI person there. Our live review is June 7th, 8th, and 9th. Is that right? Monday, Tuesday, Wednesday. It's going to be on Zoom, but we're going to be in here. She wanted to come here, but ATI will not let the instructor come. They haven't changed their policy yet that the instructor can be in person. So it will be 8 o'clock a.m. Everybody listening to me? Everybody in the other classrooms can hear me, right? Somebody give me a yes over there that you're awake and you can hear me.
Yes.
Oh, good. Okay, now I got a few yeses. Okay, so 8 o'clock a.m. will be the start, which means that you're going to get here at 7 by 7:30 like you've been. That way you're ready, you're logged in, your computer's working. I'm going to pull her up on Zoom here so that we'll just switch classes like we normally do, location. It's 3 days, Monday, Tuesday, Wednesday, 8 to 3. Be prepared that she's going to be talking through the screen from 8 to 3. It's going to be long, okay? Get your coffee, your tea, your Red Bull, whatever it is that you need to get yourself, because it's going to be a long day. But last year, we did it at home. We're not doing it at home this year because I know what happened last year. People at home didn't pay attention the entire day. They were doing whatever else, thinking that I would never know. And those were part of the 6 people that did not pass the exam. And I'm not going to let that happen this year. So we're going to come in here. She's going to be on the screen. She's going to be interacting with you guys. There's paperwork that she's already sent me on Friday that I'm going to forward to you that will be different activities that she uses for those 3 days to help us learn how to pick questions, answer questions, break apart the questions, blah, blah, blah. Okay. So it's Monday, Tuesday, Wednesday, 8 to 3. If you are here, and not if, you will be here all 3 days. She'll take attendance. I'll take attendance in here. If you're here all 3 days and for whatever reason, and I'm not claiming this for anybody, if you didn't pass the first time, they guarantee you support to make you pass the second time. But we've learned enough this year that 100% of us, let's claim it now, are going to pass the first time. But you got to be here, and those are 3 days. Before she comes on June 3rd, we're going to take our first predictor. So that's only a few weeks away from now that we're going to take that. She'll get that information, and she'll say, overall, as a class, you need a little more help with blah, 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 you know, and she'll kind of tailor what she's doing with us on those 3 days. Okay, so I'm going to be sending you that paperwork. Don't take that and do anything with it right now. It's just paperwork that you're going to use on those 3 days to do activities, and I want to make sure you have it in your hands. Did everybody in here order a PN review book? Anybody not able to order the book? Everybody got it? Has everybody received the book? Anybody in the other classrooms not get the book yet? So everybody in the other classrooms has that gray PN review book. I'm going to assume that's a yes. If you said nobody is saying that they didn't get it. So you're going to get that book in those 3 days, but you can use it before then. Again, that book basically takes all your other books that you've used throughout the year and kind of condenses it even more. But it's a very good book to use for review. And again, it's just that. It's review. Look at it. You know, there's different things in there that you might pick up on that you didn't see in the other books. But most of it should be pretty similar to what we went through in all these books. So that's June 7th, 8th, and 9th. After that, we'll take our second predictor later on that week. June 21st is a Monday. You guys will be here only until noon that day because the next class for next year will be coming in the afternoon. And they're doing their orientation and coming in, and you know, I asked a couple of people, a couple of you guys, if you're willing to stay and tell the other class like things that you've learned that worked or didn't work, or you know, something about the program. I don't need everybody to stay, but if a couple of people want to stay and kind of encourage them, like you will get through it, even if you don't think that you're not going to, because by then you guys will almost be done. And then again, graduation is June 25th. So that's kind of our plan. We already got our schedule and all of our tests from now till the end of the year. So I wanted to tell you about the 3-day live review thing with Judy. don't think there was anything else that came up on Friday. All right, so how do we feel about Peds? Are we moving along? Do we feel like it's a lot? It's a lot. It is a lot. Peds is a lot. All right, so we're going to review a little bit, and then we're going to kind of try to get through this PowerPoint. A lot of this stuff we've already talked about. There's a little bit more at the end that we haven't talked about. Different acute disorders, chronic disorders, we're talking about pediatric patients, and again, we just need to review some of this stuff like diabetes. We need to go back over it again. We know diabetes, it ties in with med-surg and review it. Okay, so if you're looking at developmental stages, you guys I'm sure have been getting questions about developmental stages, right? Like if you have a 2-year-old versus a 6-year-old, what kind of play are they doing? Everybody get this little chart here. There's no way you're going to memorize the entire chart. That's two. You're not going to be able to memorize the entire immunization schedule. But look at this chart, and the two people that we need to worry about with development are Erickson and Piaget. They're the two that are in ETI that they use. So if you're looking at like up to a year old, what are we saying that Erickson says it is? Trust versus mistrust. It should just pop in your head, hopefully, make it kind of easy. This is not on this PowerPoint. We're just talking. Again, now we move through. What are the different age groups? This is what was in your summary packet. Tell me the 10 different developmental levels, and we start at the newborn and work all the way up. If we're talking about the toddler, what does Erickson say? Autonomy versus shame and doubt. That's what he calls it. What does that mean in real life? What that means is that 1 or 2 or 3-year-old, we're talking about over 1 year of age, now they're learning yes and no. They're learning to be independent and think on their own, but that they also need to have rules during this phase because safety is a concern. So that's what Erickson calls it. Again, look at what Piaget calls it, pre-operational. And I remember all this stuff in school thinking, how am I ever going to remember all this stuff? Think about the age of the child, and that's going to determine what kind of play what would you pick for them, okay? Again, what kind of interaction or what kind of discipline is that child going to need? What they have learned is like if they don't progress through these stages, this developmentally affects how the kids learn how to behave in society, right? So there's your 1 or 2 or 3-year-old who never gets told no, gets everything that they want, and never learned the autonomy versus shame and doubt, meaning didn't learn what's right or wrong. And then you move on to, okay, now, early childhood, 3 and 4-year-old. What are we calling that for Erickson? Initiative versus guilt, meaning that they're starting to do the things on their own, but then they're learning that there's consequences to their actions. So by answering these questions, again, there's a developmental PowerPoint. You're not going to be able to remember every single thing, but by answering more and more pediatric questions, so that you can apply more and more. How old is the child? What would I expect their play looks like? What would I expect that they're going to understand? What would I expect? How to explain a procedure to a 6-year-old versus how to explain a procedure to a 1-year-old. It's going to be different. And again, you're going to just use your life experiences of my 4-year-old did this, or my 1-year-old did that, or my nephew's like this, or whatever, stuff that comes to mind based off of the age of the child. You will not get a ton of pediatric questions. You'll get some, but you're not going to get half your test will be Peds. It's going to be more med-surg related to these disorders, maybe that a pediatric patient has, like diabetes or rheumatoid arthritis or cystic fibrosis or whatever. So again, we already talked about injections. These are the disorders that are more acute because it happens right now. What did they inject? We talked about lead. We're going to pick chelation therapy for lead. It's just a medication that removes the lead. What is our biggest concern with lead exposure? Cognitive development, physical development. It slows down their growth. It changes their brain function. When are we going to see that? And when would we recommend a lead screening? Maybe that's a question that might come up. It's going to be early childhood or childhood age or school age childhood. We're not going to wait until the person is an adolescent to do a lead screening. It's going to be earlier. Same thing with that scoliosis screening. It's going to be school age child that gets scoliosis screening because we want to identify it as early as possible. So again, we just go through real quickly things that we talked about before we talk about different things. So sugar-induced vomiting, we talked about aspirin poisoning. What is the one disease that I said you can pick aspirin to treat it? Kawasaki. Remember I was talking about Kawasaki's disease where they have reddened eyes and inflammation all over connective tissue. Aspirin's okay for that job, but most of the time, that's the stories I get about aspirin because this is what happens with them. Question might come up about a person getting aspirin that recently had a viral disease. What's that going to put in risk for? Rye syndrome. So they might have recently had the flu, that's a virus. They might have recently just had a stomach virus. So giving them aspirin on top of the virus is going to create rye syndrome. Have you seen any questions like that come up? What is rye syndrome? We already talked about that. Brain damage that happens, and again, that doesn't happen as much as it used to because they don't give aspirin like that anymore to kids. But usually those who are given aspirin after they had chickenpox or the flu, either viral infections. And so let's keep moving through here. Everybody feel like we're okay with burns. Different levels of burns, what our treatment will be. Again, stop the heat, the chemical, whatever it is on the skin. Always look for your safety answer. Fractures we went over, the type of fracture you're going to see mostly kids are brain sick because their arms are twisted or they're physically abused. Here's our pains. This is back to a med surg section of whatever we want this year, our 5 Ps of fractures, circulation issues, pain, pulse, power, paresthesia, paralysis. We know what all those mean now. I don't think we need to review that again. We talked about the treatment option for compartment syndrome is a fasciotomy. That's our biggest concern if somebody has passed on. Here's our nursing responsibilities. Again, this is just reviewing what we talked about last week. So all I want you to do is just look through the PowerPoint, review it. This is all med-surg stuff that you should hopefully know by now, but we've learned so much that you kind of forget some of that stuff. So you got to go back and kind of remember what is compartment syndrome, what are the 5 Ps, what are the things that I would be looking for in my answer. And again, the question's not going to say give me the 5 Ps, it's going to be in the answer that you're going to need to try to find those things that you would be looking for if you were the nurse. Again, somebody with a fracture or an open wound, always remember to give them that tetanus shot. If we're not sure, give it to them anyway. We're talking about the difference between open and closed fist fractures. Okay, here's traction. We already went over that the other day. Just a review. Rope should hang freely. Again, there's different types of traction. We're going to do pin care frequently. Occasional skeletal traction. Again, the P's still apply to the person in traction. They're always going to be checking their circulation. Don't forget that. And again, I think you guys will be fine with those fracture questions or traction questions. We went over all that stuff when we talked about musculoskeletal. There's a Kawasaki syndrome. That's the person that, it's just a rare question that might pop in any class. Most people don't get a question, but I have had students say, hey, I need one question about that. Cardiac complications are going to be your biggest concern. Everything in their body, their connective tissue throughout their body is inflamed and red. The set rate's going to be up. It could last for weeks. We're going to treat this with aspirin. That's okay to use for this syndrome. Okay, there's our physical. We talked about Munchausen syndrome before. We went over eczema the other day. Okay, we talked about asthma, pick albuterol as your answer. And MDI, we know what that is. It's just a short burst of medication. It's a meter dose inhaler. It specifies how much we're getting right now. The reason why we mentioned it with kids is because we use MDIs a lot with kids, so they don't overdose on the medication, because they don't get the same amount as an adult does. So there's our inhalers that we talked about. Rheumatic fever, we went over that. What is it? Inflammatory disease that involves the joint, skin, brain. What are we getting in order to diagnose that? A rheumatoid factor, that's a lab. We're getting a SED rate, that's a lab. We're getting a CBC, the white count's going to be elevated. There are the things that you should be thinking about. If a patient has rheumatic fever, what's the biggest concern when it affects our heart and it affects the child's heart? And that's the most significant complication of this. When is this going to happen in your story? After the patient recently had strep throat or some kind of infection recently, respiratory infection, it usually comes after that, 2 to 6 weeks after upper respiratory infection. And that's typically how they ask you it in a question. So that would be part of your history or your screening that you would want to do for that patient. We went over rheumatic fever already. We talked about scoliosis the other day. There's mild, moderate, and severe. Mild is just going to be physical therapy. Moderate is going to be something called a Milwaukee brace. They wear it 23 hours out of the day. If it's severe, you're going to have surgery. Again, I'll show you some pictures. How are we going to know from the screening? How else can we tell? The hips are uneven. That's one way, and or the shoulders are uneven. One's higher than the other based off of that S curve that's in the spine. And I know I'm going kind of quick, but we've already talked about all this stuff, and I'm pretty sure that you're okay with it. You just need to review. Look how that one shoulder is higher than the other. That might be the thing that's in your custom, and that might be part of your screening that you notice for that time. The most common spinal deformity is scoliosis. 10% of it, lots of difference in that. And there's a C or S shape of the spine, asymmetrical hips. This one hip is higher than the other, this one shoulder is higher than the other. And how are these done? Screenings was done in school, right? But now a lot of kids weren't in school, so a lot of that stuff is probably not been done. If it had been done, typically it's a school nurse that does the screening or your pediatrician. So there's the brace and the Milwaukee brace. Again, observe for skin breakdown. You're never going to pick like any powders or creams or lotions underneath that brace. All you're going to pick as an answer is wear a light cotton t-shirt under the brace, not a big sweater, nothing heavy. Okay, so let's keep moving through. There's your Milwaukee brace, and that's just a picture of the child wearing that. And we talked about that the other day. Juvenile rheumatoid arthritis, it's the same thing as rheumatoid arthritis in an adult, but it happens in a pediatric case. And we talked about the symptoms of that. So, diabetes. Diabetes in a kid. We just need to go back over diabetes because 100% of you guys are going to get diabetic questions. It's a fact. It's on NCLEX. They want to know that you know diabetes. Look at the chapter in your pediatric book. Let's find it and let's go over 217 in my book. I don't know what it is in your book. So what is it? Let's just begin at the beginning. Two different types of diabetes. We know there's type 1, type 2. What is type 1? It basically is from the destruction of beta cells. What are beta cells? They're in our pancreas, and they make insulin. So that's your kid that develops type 1. So typically, your pediatric patient is never, hardly ever, type 2. Remember we said type 2 is later adult onset. Type 2 is related to obesity, sedentary lifestyle. It's related to basically the insufficiency of the insulin that you're now making. So type 1, they don't make insulin. The beta cells don't produce it the right way. And so that's your kid. That's your 8-year-old that's developing diabetes. What's our signs that we're going to see if we are recognizing that they have diabetes? Somebody give me a sign of hyperglycemia. What is it? Yeah, all the P's. What's the 3 P's, Vicentia? Yep, you got it. Good answer. Polyuria, polydipsia, polyphagia. There's your 3 P's. How are we going to know that's happening? That's your pediatric patient that all of a sudden might be saying in your story they're wetting the bed. And what it might say is enuresis. That means you're peeing in the bed at nighttime. That's a new thing for a 9-year-old that shouldn't be doing that. What else are they? They say they're thirsty all the time. They're peeing a lot. They feel hungry all the time. They have signs and symptoms of the blood sugar being low or their blood sugar being high. That's your pediatric patient, and we're going to diagnose them with type 1 diabetes. It's not going to be type 2. Your 40 or 50-year-old that is overweight and their BMI is high and they have sedentary lifestyle and they don't exercise and they don't have a good diet, that's your type 2. Okay? So you got to recognize why we're talking about diabetes with kids, it's type 1. And they're the kids that are your 8-year-old, your 10-year-old, your 12-year-old. That's why it's called juvenile onset is type 1. That means it usually happens with kids. So what are some of our risk factors for developing that? Genetic is one of them. So if you have a parent that has diabetes, the child's more likely to have diabetes. Type 1 is considered autoimmune. What do I mean by that? What did we just say? Your own body destroys your beta cells. The beta cells are what makes insulin. So type 1 is your kid that has that autoimmune disease, or they genetically have a link for diabetes. You can develop diabetes from exposure to viruses. Your pancreas can get damaged, and now there's damage to your pancreas cells. So again, we don't always know the reason, but what we know is these are the things that attack and destroy our beta cells, and now it leads to type 1. What do we know about type 1? What are we going to look for in the answer? Because we have to get diabetes questions right, because we got to know it like the back of our hand, because there's other questions that'll come up that'll be harder than diabetes. So we got to know diabetes. We got to know insulins. We got to know short-acting, long-acting, signs and symptoms of hypo, signs and symptoms of hyper. That's what's going to be your diabetic questions. So what do we know about type 1 with a child that we're going to look for in the answer? What is going to be the treatment for that? What'd you say? Insulin. Perfect. That's the answer. You're not going to pick that you're going to give them an oral medication. Everybody with me? Because that's type 1 means they need insulin. So you're going to pick something in the answer that says training, new training on insulin, right? Or education on different types of insulin, or whatever, something about insulin in the answer. Consider an insulin pump or whatever it is. Because type 1 has to have insulin because they don't make insulin. So pills are not going to work. Type 2 diabetes, that's your 40, 50-year-olds, 30-year-olds, however old they are, that now can start the diet and lifestyle modification, right? Remember that stuff? And now they can proceed to pills. If the pills don't work, now we start insulin. So that's all the people that we can take care of in clinicals that have type 2 diabetes. What's the percentage? About 80% of the people have type 2. Only about 15 to 20% have type 1. But type 1 is going to be your pediatric patient. That's why we got to go over it again with Peds. So again, could obesity make the type 1 diabetic? What if you have an obese child that's 200 pounds at 8 years old? Because there's kids out there that are obese. Couldn't that trigger the symptoms of their type 1? Sure it could. I mean, being obese and overweight is not going to help them. But basically, their reason is autoimmune to begin with. So they got to have insulin. So you got to treat them with insulin. Type 2 is this high risk of all these things: lower activity, obesity, high triglycerides. Do you remember us talking about something called metabolic syndrome? Okay, remember what that is. What is that? That's your adult patient that has all these things going on: higher triglyceride, higher cholesterol, hypertension, obesity. It's a syndrome of all these bad things that they're not taking care of themselves, and they're going to be more likely to develop type 2, hypertension, heart disease, kidney disease. It's called metabolic syndrome. So that doesn't really happen with kids. It happens more with that 40 or 50-year-old that's not taking care of themselves. What's our signs, Aaron, of hypoglycemia? If your story says the patient has a blood sugar and they're 10 years old, they have a blood sugar of 45, what signs and symptoms are we going to expect? Give me a couple signs and symptoms. Cool. Give me another one. Pale. Yep. Give me one more. Take one more sign and symptom. We got to know these signs and symptoms. Write them down if you don't know them now, because this is what's going to be in your story of your hypoglycemia patient. Pale, cool, clammy, right? Need some candy. What other symptoms? Chandler, give me another symptom. Blurred vision. Think about a kid though. What are we going to see in a kid? Because they're not going to be able to tell us they got blurred vision. That's a good thing for an adult, because an adult can say my vision changes. But what about a kid? Crying, irritable, restless, diaphoretic. Remember, we talked about that? What did somebody say? Maybe the kid has slurred speech. Yeah, this is what you really see in adults too, right? Have you ever walked in on a patient that has hypoglycemia? What do they look like? Pale, cool skin, just like you said, blurred vision. The child is going to be irritable, restless, diaphoretic. What about their heart rate? Is it going to be up or going to be down? Up. It's going to be up. They're going to be tachycardic. What about their level of consciousness? Are they going to be awake and alert, or are they going to be kind of sleepy, lethargic, sleepy? So there's your kid that maybe you can't arouse, right? No kid is going to be able to tell you these symptoms, so you have to be able to pick up on it in your story with your pediatric patient that's only 2 years old. They're not going to be able to tell you my vision is blurred like an adult can tell you, so you got to find other things. But again, slurred speech is good. I could be for any kid that's talking, that normally can talk clearly and now they can't talk. What about a headache? That's a sign of hypoglycemia. So vision changes, headache, slurred speech, lethargy. Could they be hungry or lightheaded? That's a sign of hypoglycemia, right? Again, you're looking at this chapter here, 32. Go back over this. Please tell me everybody will go back over diabetes. You're going to have a med surge packet in another week or two that has diabetes questions. But 100% of you guys will get diabetes questions on MCAS because it's a disease that a lot of people have and they want to know that you know it. So what's my signs and symptoms? What else about a child? They could get anxious and restless. Maybe that's all you see, is that they're anxious and they don't really know why. So that's a blood sugar less than what? What's our normal fasting blood sugar, Australia? 70 to 110. So can somebody have symptoms with a blood sugar of 60? Yes. Can some people be fine? Yes. Some people are. What's going to be our answer to treat them if they have a blood sugar of 58 if they're fine? 15, 15, 15. Go back to what you learned about diabetes. Give them 15 grams of carbs if they're well. So let's go back to what here. Write these down because these might be the star 12 or the 5. What are my 15 grams of carbs going to be? 4 ounces of what? Would it say sweetened juice or unsweetened? Doesn't it say unsweetened? And it makes no sense. And we're like, what? If it says 4 ounces of orange juice, pick that. If it says 4 ounces of unsweetened juice, it's okay to pick that. And even though I say, wait, is there sugar in it? There's still that sucrose in it. What about, do we want to pick 4 ounces or 8 ounces of Diet Coke? No. We want to pick regular. Okay, what about glucose tablets? How many are we going to want to pick? 3 to 4 sugar tablets. That's a good option. Pick that. 4 ounces of juice. What about milk? Is that a good choice? Yeah. For mild reactions, milk might be okay, but don't pick that as your best answer. Why? What did we say about milk? It takes a little longer for that sugar and then milk to get processed. So this is what we're picking, 4 ounces of orange juice. What they want is 8 ounces of milk. If that's an option, that's okay to pick. You can pick 3 to 4 glucose tablets or 4 ounces of your regular soda. Okay, these are your options. That might be your select five. For your patient that has hypoglycemia. Now, what if the story says the child is unresponsive? And again, we just talked about that patient at Paramount that had a seizure. Is the Ativan in the side of the mouth the best option? If we could give IM, probably that would be better, but maybe they don't have IM there. Maybe this is their protocol. Again, what could we then do if they're unconscious or we can't get them to swallow 4 ounces of juice? What are we going to pick? Glucagon. How are we going to give the glucagon? Sub-Q or IM? There's your way of giving glucagon. If you're not aware of that, there are some options of sugar that come in a sublingual form. You could do that as well because you basically just squirt it under your tongue. So if you're looking for something in your answer about hypoglycemia and the patient is unresponsive, it could be glucagon IM. That's okay. It could say glucagon sub-Q. That's okay. That's a way of giving sugar to somebody that can't take the 4 ounces or would aspirate the sugar tablets or whatever. Pick that. They're okay options. Again, what are we doing then? 15 minutes, we're checking the blood sugar again. If it's still low, we still have symptoms, we're going to repeat it. Again, you're looking for what's my nursing care for the patient with diabetes. And I haven't changed any slides, so we're not missing anything. We're just talking about diabetes. What's our nursing care for the child that has diabetes? That we would be part of our education for them. Would we want them to have a consistent diet? What do I mean by that? Make sure they eat 3 meals a day and snacks. Why? Because what you don't want to happen is the blood sugar to go up and down. Now, do we eat 3 meals a day and snacks in between? Yes? No? We probably might eat more than 3 meals a day, right? Or you might be somebody that eats breakfast but then doesn't eat again till dinner, right? Again, think about what your normal eating habits are like. What you want with a diabetic is a consistent diet. Always pick that. Pick it, good intake of fluids. That's okay. Do we want them to drink sugary drinks like cola all day long? No, right? We want to teach them drink Diet Coke. Have sources of sugar in their diet should be natural sources like fruits. They should have vegetables. Go back to what we learned. What's the balanced plate for the diabetic patient? It's split in 4 parts. So how many parts of that should be a card? Only 1 part. Remember, like 25%. Remember when we talked about that before diabetes? The reason I'm going over diabetes again, yes, we're still in peds, but guess what? Pediatric patients get diabetes. And you're going to get diabetes on the cuts. So your carb 25%, 50% should be vegetables, right? Fruits and vegetables, and another 25% should be that protein. Okay, remember that's your balanced diet. So is it okay that the diabetic patient has some starch in their diet? Yes, it's okay. We don't tell them you can't ever eat starch again. You can't ever have a piece of cake. But what you can't have is most of your diet consisting of 3 plates of pasta every day, because that's just carbs and that's just going to make your sugar high. What about diabetic patients do we have to pay attention to? Let's think about their skin. What about their skin? How often should they be inspecting their feet? Daily. How does that come up for you? What about their toenails? What could be a good option? Cut them straight across. That's okay. Have you seen questions like that come up? Right? Or if there's an answer that says the patient doesn't understand teaching about toenail care or skin care, now you can refer them to a podiatrist. But again, you're teaching them cut straight across. That's okay. What about shoes? What kind of shoes, Lauren, are we telling diabetic patients to wear? Closed toe. Can they wear sandals in the summer? No, they shouldn't. Do you see diabetics with them? Yes, absolutely. But here's our best answer. Closed toe shoes, no sandals in the summer. Again, what you're thinking about is any kind of sore that they might have. So should they walk barefoot on the beach? No, that wouldn't be a good option for them. Should they wear socks when they put their shoes on? Why?
To prevent moisture.
To prevent moisture and pressure against any part of their heel or their feet or whatever. So what kind of socks? Cotton socks, right? That's okay to pick. Again, monitor their skin. You're going to be telling them, what do we think about infections in the diabetic? More frequent, more likely to get infections?
Yes.
UTIs. So there's your 6-year-old little girl who has diabetes who now is getting frequent UTIs. That's the picture that you want to see. Because she has a high blood sugar, more likely to develop infections. Again, what about their diet? Should their diet, we said it should stay consistent, but should they eat kind of similar things every single day? We talked about that with the diabetic patient. Can they have a little bit of pasta? Yes. But where they run into a problem is where all of a sudden on one day, they have 2 big plates of pasta. Now the sugar is going to go up. So again, stay consistent kind of diet, consistent kind of meal planning. Calories and food should be the same pretty much every day. How about high fat? Is that a good option for the diabetic patient? No. High carbs? No. Again, what do we tell our child that's participating in team sports? Because this is a pediatric patient now that has diabetes. What should they do about 30 minutes before their soccer game? Have a snack. Pick that as your option. 30 minutes before an activity. Why? Well, we know about exercise that lowers your blood sugar. Doesn't make it go up, it makes it go down. Again, if they have, let's say, a soccer game that's now going to be 2 hours, that's your story, 3 hours for your 10-year-old, what are we going to tell them to do about 60 minutes in? Have a snack. So there's your diabetic patient who might be half time of their soccer game. This is real life. Have a snack, because the more that they're running, now what's happening with their blood sugar? It's dropping. Again, so what about have you seen any questions come up about taking insulin before the activity? Right, it says not to, or maybe decrease the dose of your daily insulin before your soccer game. Sometimes that is exactly what we do with kids or people that are active or headed to the gym or whatever. All right, so again, there's low insulin that we're talking about. Now, what if they run high? What is diabetic ketoacidosis? What is that? That's a complication from diabetes. Typically, the patient's blood sugar is usually above 300. What do we mean by ketoacidosis? How are we going to know they have ketones? In their urine. The urine's going to be positive for ketones. What are we going to recommend that they do? Take their insulin, notify their doctor. Again, they're going to be acidotic. So what kind of ADG is it? Is it respiratory or is it metabolic? Metabolic. Where's their pH? It's down. Where's their bicarb going to be if it's metabolic? Is it going to go down or is it going to go up? It's going to go down because metabolic equal. It's going to go down. So what's normal bicarb, Brianna? Perfect! 21 to 28. Look at all these numbers we know now. You guys are amazing. I told you the most you're going to know is going to be on June 25th when you walk out this door. By next year, you'll be like, I don't know. Right? I'm not working. I'm working at Meadowwood now. I don't need to know that. But right now, we need to know everything in order to pass this test. So bicarb, 21 to 28, right? It's going to go down if they have diabetic ketoacidosis. So what are we going to have to do? We're going to have to increase fluids for that patient. That would be an answer. If they're in diabetic ketoacidosis, where do we think their potassium is going to go? Up or down? Up. It's going to go up initially. It's going to be above 5. That's your normal cutoff. So what can we do? We're going to give you IV fluids. We're going to try to flush out the potassium out of your system. Could we give you diuretics to try to get some of that potassium out? Yes, we could pick that. Another thing that we do for diabetic ketoacidosis is actually give them regular insulin, IV. That's what an RN would do. And that helps bring potassium out of the cells. So you might see that come up. So again, you're going to provide what kind of fluid? What do you want to pick? What kind of fluid would you want to give this patient? Normal saline or lactated regular, something that's similar to their composition, right? And again, as in time with the insulin dose and the fluid, hopefully that blood sugar will get down. I'm certainly not going to give them anything that has high sugar content. You're going to monitor potassium levels if your story says they have diabetic ketoacidosis, because that's typically what kills them is the potassium goes up too high. So you might give them diuretics. You're going to give them IV fluids. Could you give them sodium bicarb? Would you want to give them that? What do we say about the bicarb level? Is it going to be up or down? So wouldn't it be a good option to administer sodium bicarbonate? Right? Wouldn't that make sense? Because their bicarb level's down. Why would I give them that? Well, their pH is down. What do we say bicarb is? Is it an acid or a base? It's like Tums. It neutralizes. It's a base. So it's okay to pick that as an option, administer sodium bicarb or anticipate sodium bicarb. Everybody with me now that we can all critically think. Why would we give that? Because the bicarb level is going to be down. So we're going to give sodium bicarb. We're not going to give potassium because the potassium level is high. Again, is this life-threatening? Yes. People can die with diabetic ketoacidosis. So again, a kid that has diabetes, we have to tell them what's your signs and symptoms of having a really high blood sugar. You know they were polyuria, polyphagia, polydipsia. What else can that kid get like if they're really, really high? They can get weak. They can get lethargic when it's high. So you're like, well, how am I going to know if it's low or it's high? Lethargy happens with both of them. You're going to check your blood sugar. And if it's 350, you know that they have hyperglycemia. So then if they're high, and they have diabetic ketoacidosis, what kind of respirations do we say that they have? What's the word?
Too small.
Not Chain Stokes. Chain Stokes is your dying patient. Poo smalls. What do I mean by, so that might be in your story, poo smalls respirations. Okay, so what do I mean by that, other than us just memorizing what the word is? Rapid and deep. Rapid and deep breathing. And what does their breath seem like? Fruity, a fruity odor to their breath. Look for that in the story. It's going to give you some of these signs and symptoms, and you're going to say, hey, I know what's going on. It's diabetic ketoacidosis. I'm going to anticipate checking the blood sugar. Right? Hopefully, this isn't things that we haven't heard before, but it's good to hear it again because we've been diabetes a long time ago, right? So these are your education things for a mom who now has a new diabetic kid, but she doesn't know a thing about diabetes, right? These are signs and symptoms of hypo and hyper. Go back. Everybody promised me I'm going to read this chapter and I'm going to go back and look at diabetes again, because one of the things that we have to know leaving this school is diabetes, because you're going to get questions about it. All right, so how are we going to diagnose that diabetes if the kid has it? We're going to get a fasting blood sugar. What do I mean by fasting? They've been NPO for at least 6 or 8 hours. There's your fasting sugar, so it should be 70 to 110. Could we get an oral glucose tolerance test for this patient? Yes. Same thing we do with our pregnant mom, right? So now we can send them for this glucose tolerance test, and now let's talk about that. What do we know that? They're going to get there, they're going to be fasting. They're going to get sugar in the morning before they drink anything. We're going to give them 60 grams of this sugary, yucky stuff to drink, and then we're going to check their blood sugar. How often are we checking their blood sugar if they're getting a glucose tolerance test? Every 30 minutes. If it said every hour, it might just be what LabCorp does. But it's typically every 30 minutes to every hour, we're checking their blood sugar for at least 2 hours, if not 4 hours. And remember, if they failed the first time, now we send them for that 4-hour glucose tolerance test. So what do I mean by failed? If they start with the sugar after they drank the 60 grams of 200, where do you think the sugar should be in 30 minutes from then? It should be going down. It went from 200, it should now be 160. And then 30 minutes later, it should be 140. 30 minutes later, you should be back down to 110. What does that mean? Your body made insulin and got your blood sugar down. Does that make sense with the oral glucose tolerance test? Somebody that's diabetic, how do we look at, what else can we look at that tells them what their blood sugar has been for the last 120 days? What's it called? What's the word? What's it going to say? Glycosated hemoglobin A1C. Not normal hemoglobin. Don't get confused, because normal hemoglobin is 12 to 16. Glycosated hemoglobin A1C. Okay, where do we want that? Less than 7. So, again, critical thinking tells us if your child has diabetes and they have hemoglobin A1C of 9, what does that mean to you? It's not controlled. If they have a hemoglobin A1C of 5, what does that mean to you, Victoria? I got a 9-year-old diabetic child. Mom doesn't know a thing about diabetes. I'm working at AI. And the doctor sends him to get a hemoglobin A1C, and it comes back as 5.2. What do you think about that if you're the nurse taking care of this 9-year-old child? That's a normal range. That's okay. What does that mean? Well, your child has diabetes, but it's been pretty controlled with whatever treatment option the doctor has said. Everybody understand what I mean by that? Because that's how the questions you're going to need. You're going to have answers, and you're going to need to look at the number and say, okay, what would I do if I really was a nurse and I saw this number? How do I apply this? So if they have a hemoglobin A1C of 10, what does that tell you, Control, about their blood sugar? Besides too high, for the last 120 days, what's happened? What does it mean? What does a hemoglobin A1C mean? Maybe they're not. That's sometimes how we diagnose a kid with diabetes. We say, hey, your hemoglobin A1C is 11. That means for the last 120 days, you've had a consistently high blood sugar. And guess what mom will say or the kid will say? I did. I didn't know that, right? Really, I mean, that's real life. So your number above 7 tells us, kind of gives us an indication of how controlled your blood sugar has been for 120 days. Do we have to be fasting for a hemoglobin A1C? No, why not? Because it's not a one-time thing. It's a level that tells us what's been happening for 3 months, right? So these are just some ways that we diagnose people with diabetes. We could get fasting sugar. We could do an oral glucose tolerance test. We could look at their hemoglobin A1C. We can now look at their signs and symptoms of what's been happening. And then now, guess what? This kid now sees an endocrinologist because they have diabetes. So we have to remember what numbers we're looking for, but not just memorize the numbers, but how do we apply it to the kid that has diabetes. So now we talk about nursing care, what we would do. Okay, now we're going to talk about insulin. Because we need to know insulins. Remember, we had that little chart on different types. So, Judith, what's our rapid acting insulin? How quickly does that start working? Rapid acting. That's regular. That's short acting. There are 4 categories: rapid, short, intermediate, and long acting. We got 4 categories of insulin: rapid, short, intermediate, and then long acting. So I'm talking about rapid. So what's the name for rapid that you would see? Lispro or Humalog. We've seen that come up, right? There are rapid acting. So now that I kind of gave you a little background, how long does it take, Judith, for rapid acting to kick in? What's the quickest insulin that kicks in? How long? Yeah, the rapid acting, but how long does it take? How quickly does it work? Yep, you got it. 15 minutes, perfect. Good answer. 15 minutes, that Lispro, that rapid acting is kicking in. Okay, great. Now that we got that memorized, what does that mean to our story? That means that we're not going to give that unless there's food right there in front of the patient, right? Unless we know that the patient's eating breakfast right now and we've checked their blood sugar. So it kicks in 15 to 30 minutes. So we don't go in the room at 7 a.m. thinking that we're the nurse of the day and we're going to get all our meds done by 9 o'clock and give our patient rapid acting, but breakfast doesn't come till 8:30. Because what if their blood sugar was 80, right? It's within range, 70 to 110. But now we gave that rapid acting and they don't eat for another hour and a half. Guess where the blood sugar is going to be? It's going to be 40 or 50 before the breakfast rate is there. So you have to pay attention in real life, and this is serious stuff. Insulin is a very high risk medication. Why? More likely to make a mistake. Have you heard that before?
Yes.
Okay, so insulin, rapid acting, 15 to 30 minutes. The name of it is Lispro. Might say Humalog, just depends on who made it. What's the peak? 30 minutes to 2 hours, it's going to peak. How long is it going to last? 3 to 4 hours. So is rapid acting Lispro something that we only give once a day? No. Why not? Because it's gone in 4 hours. Everybody understand what I mean by that? It's not in their system for 24 hours. So we give Lispro 4 times a day usually, or every 4 hours when we're checking the blood sugar. The patient might get Lispro. But again, you got to make sure that you check the sugar and they got food in front of them and they're going to be able to eat. What am I going to think about Lispro if the story says my patient's vomiting and throwing up and keeping nothing down? I better be darn careful not to give that medication, right? Because they're not keeping any sugar in their body. I move on to your short-acting insulin. Sierra, what's the name of the short-acting insulin? We moved on from rapid, so Lispro is our rapid. It starts working in 15 minutes. Now we're talking short-acting insulin. What's the name of that? Starts with an R. Phone a friend. What'd you say? You say it, Latoya. Regular insulin. Yeah. The R that's on the bottle for that regular insulin, that's short acting, not rapid acting. Okay, so it's easy to get those confused. So our short acting is regular. Okay, Cynthia, how long, what's the onset? How long does it take regular insulin to start working? 30 minutes, yep, there it is. It doesn't kick in 15 minutes. It starts working in 30. Okay, what's the peak for regular insulin? 30 minutes, all the way up to 3 or 4 hours, it's gonna peak. Now the duration, what does that mean? How long is regular gonna be in our body? 4 to 12 hours. So again, look at the chart that's in here. Go back over different types of insulin. It's going to be on your med-surg packet I'm going to give you in a couple of weeks, but we're just talking about it here. What can we not mix? Can we mix Largon with anything else? No, so don't pick that as your option. Now we move on to our intermediate acting. So Maggie, what's our intermediate acting insulin? MPH, there it is, our intermediate. So how long does that take to kick in? That's your onset, 1 to 2 hours. When does that peak? This is a key thing because these questions have come up for us already. When does intermediate peak? This says 6 to 14 hours. So what does that mean for the story? What that means is if the patient got MPH at 8 this morning, when did I say you're going to look for that decreased blood sugar? Sometime in the afternoon. 2, 3, 4 o'clock. There's when it's going to still keep working and it's going to peak. Remember how we said the regular is going to peak much quicker. The regular peaks, according to this ATI book, in 20 minutes up to 7 hours. It's much quicker. Regular usually is way gone by 7 hours. That's a long peak time for that regular stuff. Intermediate doesn't kick in 20 minutes. It kicks in 1 to 2 hours. So that means we're okay. We can give you MPH. Your breakfast is coming. You're eating this morning. I don't expect if somebody got MPH at 8 o'clock and they have hypoglycemia at 9 o'clock, it's not the MPH that did it. You understand what I mean? It's the regular that did it. So you have to look at when did they get what time of insulin. The MPH, when you're going to have a problem, is 2 or 3 or 4 in the afternoon. That's why people get snacks in the afternoon, so they don't drop because of the MPH. How often every day do we give MPH? If the duration is 12 hours or 18 hours, how often a day could you give MPH? At the most, twice. At the most, twice a day. You do not give MPH every 4 hours, so that will never be your answer because it's so long, it stays in your system. So if you gave it every 4 hours, you have all different reactions in your body because MPH is kicking in for 4 to 12 hours. You understand what I mean? Regular, you can give 4 to 6 times a day. That short acting, you can give 6 times a day. But MPH, you only give once or twice a day. You're going to see people's MAR say MPH insulin, BID, 7:30 in the morning and 4:30 in the afternoon. Okay, so if they got a dose at 4:30 in the afternoon, now when's that MPH going to kick in? Well, what's 4 to 12 hours or 6 to 14 hours from 4:30 in the afternoon? You're talking 9 o'clock, 10 o'clock, 11 o'clock at night, right? Isn't that when everybody's going to sleep? That's why we give them their nighttime snack. So their blood sugar doesn't drop in the middle of the night. Everybody kind of understand insulin because we got to understand this because when you get it in your question, it's going to be a question you have to think about. What did they get? And when am I going to worry about it kicking in? In real life, in a couple months, you're going to have to think about that. I'm giving insulin. When am I going to anticipate this reaction? Does that make sense? I might know we're further confused.
When we practice mixing regular with our MPH, is our goal to have the onset of regular with the long duration of the MPH?
Why does somebody get regular and MPH at the same time? Yes. The goal of mixing 2 insulins together is one, to give the patient with 1 shot. What can we mix together, regular and MPH? Why do we do that? The regular takes care of their blood sugar right now. They're about to have some pancakes and eggs for breakfast, but it takes care of them not going up to 300 after they have their breakfast. The NPH regulates them for the next 6 to 14 hours throughout the day. So we kind of give combination, right? Once in the morning, once in the afternoon, might be all the insulin people get. Some people get insulin every 4 hours. But again, why would somebody need insulin every 4 hours? That's typically the patient that's in the hospital that's sick and the blood sugar is running high. And we try to keep it under control as much as we can. Most of the time, people at home are doing twice a day insulin. For exactly what you just said. Regular right now to keep it down because I'm going to eat some dinner or breakfast or lunch. And then the NPH to kind of keep it regulated throughout the rest of the day. And then I go to dinner time and I check my blood sugar again. And I give myself. And typically, what do you think about the dose of the regular NPH? Do you think we give more in the morning or more in the evening most of the time? More in the morning. Why? Because most people eat more during the day, right? So your dosages of insulin are usually, and I say usually, going to be higher in the morning because what do? We get up and we eat breakfast and then we eat lunch and then we eat dinner. Are we all eating all night long? Hopefully not, right? But, again, you got to look at the peaks. When is it working? So here's our long acting. What's that going to be called? It's either going to be called Glargine or Lantus. It means the same thing, just depending on who made it. What do we know about the peak of that? Is there a peak, or does Lantus peak? No. How many times a day do we give Lantus? Only once. So never mix Lantus with anything. Never give Lantus 4 times a day. You're going to kill the patient because the Lantus doesn't have a peak. How long does it last? 24 hours. So why does somebody take all of these different types of insulin? Again, this is a diabetic that's probably had it for years. And basically, we control their blood sugar right now with the regular, but we give them the Lantus to try to help control the blood sugar throughout the day. So what's our sequence? Because this will be a drop and drag question for you guys. What's your sequence of mixing regular and NPH? What are we doing? Nancy Reagan, RN. We're putting air. Everybody's got to get this right because I'll bet you get the class and I'll get this on our class. What are we doing? We're putting air in the NPH first, right? Everybody with me? Putting air in the regular. Drawing back the regular, right? And now going back to the NPH to draw up the NPH. Everybody okay with that? Because that's going to be your drop and drag. I'm going to put them in order. What I'm doing, Nancy Reagan, RN, clear to cloudy, all those things should pop in your head. If it asks you to mix the Glargine and regular, don't pick that. That's not an option. If it asks you to mix the rapid acting Lispro with the Glargine, don't pick that. That's not an option. So don't let it trick you and well, I guess I could do it this way. You can only mix certain kinds. So you gotta know the sequence of it. Now, how are we administering it in ATI world? It's gonna say at a 90-degree angle and it's sub-Q. What kind of needle are we gonna pick? We're gonna pick a TB syringe, an insulin needle, right? Not a TB syringe, an insulin needle. And what kind of needle device does it have on the end? It's shorter. It's typically a 1/2 inch to 1 inch because it's sub-Q. You're not giving insulin IM. So don't pick an 1.5 inch needle to give insulin because that's what you're giving. You're all the way into their muscle. You want to give it into sub-Q fat. What's the gauge? It's typically going to be 25, 28. It's a higher number gauge. I know we talked about all this stuff before, but we forget all this stuff, right? We got to go back over it. We're not going to pick 16 or 18 gauge. It's going to be a higher gauge number and a smaller needle because it's sub-Q. Again, that's why we're going back over it. Sub-Q can be 45 or 90 depending on the patient. Don't be afraid to administer it 90 degrees with a 1/2 inch needle. Because even if I go in 90 degrees into my fat patch right here, I'm still only in sub-Q tissue. If the only option is 45 degrees, now you're going in at 45-degree angle, that's okay. That might be for the really skinny person that doesn't have a whole lot of fat to go into, or it might be for your really fat person that 45 degrees is still in fat. Look at the answers, look for your best option. Don't get trapped into, okay, I never gave insulin 90 degrees. We do that all the time. There's a lot of fat people that have a big fat pad. The secret to not giving it IM is the length of the needle itself. What if I only have a little tiny bit here for this really skinny, 75-pound, 90-year-old that I'm taking care of? I only got it for my arm. It's a lot fatter than somebody that's 75 pounds. Now what if I go 90 degrees for that person? I'm probably IM. So then I might want to do 45 degrees. You understand what I mean? Like, think about what they tell you about the patient. What an older adult patient that weighs 70 pounds, maybe you might want to pick 45 degrees. Because if you go in 90 for that person, you might go into muscle. But most people, 90 degrees, you're not going to get into a muscle. So that's okay to pick. Again, how do we give it? Why do we rotate sites? What's the word we're trying to prevent? Lipodystrophy, or whatever the dystrophy at the end. Lipohypertrophy, it might say that. What does that mean? Scoring tissue, because I use the same site over and over and over. So then I can rotate the sites. So again, I know you're like, oh my gosh, I know diabetes. We just need to go back over it because we got to know it well in order to get the diabetes questions right. So here's our hypoglycemia, less than 70. Here's our hyper, usually right around 250. We call it ketoacidosis, or usually above 300. When does urine show positive for ketones? What's your blood sugar above? Usually above at least 200 for us to even see the ketones. So do you want to pick that as a good option to teach somebody at home? No. Why? Because by the time you have ketones, it's already higher than it should be. So yeah, you could use that, but that's not our best screening. We want to look more for symptoms. Here's our 3 symptoms: polyuria, polyphagia, polydipsia. High, hot and dry, sugar high. So they're hot skin, they're going to be flushed, their face might look flushed. They have skin turgor, they're going to be dry mucous membranes, and they're going to be dehydrated. Because we know they're dehydrated, what are we going to pick? Give them IV fluids. We're going to pick normal saline, lactated ringers. We're going to monitor their potassium because it's usually high. There's a small, rapid, deep breathing with fruity odor. What's the difference between that and chain Stokes? Chain Stokes is usually a pattern of apnea and then fast breathing. And that's usually your dying patient. That's usually your patient. If the story says the patient's on hospice, they're exhibiting chain Stokes respirations, their blood pressure is 60/40, they are a DNR, what's your answer going to be? Exactly. That might be your answer. Don't be afraid to pick that, right? Let them die. Prepare for whatever. I don't know what the wording will be. I hopefully won't say let them die. But the wording will be there in the story. If they're hospice and a DNR and they have chain Stokes and their blood pressure is low, what could our answer be? Comfort measures, right? That's probably what our answer is going to be. Have you seen any questions come up like that? All right, don't be afraid to pick that. Now, if it's a full code, like if the person like Christiana, we're not going to do comfort care. You know, again, I don't know what the story was with this guy, but think about whatever the story says and do what you would think they did the right thing. So here's our signs and symptoms. Again, we just talked about these things and went through them. How do we diagnose it? We're not going to just diagnose it by one day of having the blood sugar high. We need separate days. We're going to come back. Blood sugar above 200, and it doesn't matter if you ate or you didn't eat. If you had breakfast or you didn't have breakfast, it still shouldn't be that high. Fasting blood sugar. This one says above 126. Again, you know, fasting for HCI is 70 to 110. 2-hour glucose tolerance. We want to be below 200 at that 2-hour mark. We want to know that your body is going to make insulin and get you back down, and it should continue to come back down. Okay, here's our fasting blood sugar. They have fasted for at least 8 hours, no food or drink, and they can have a little bit of water. Again, what do we do with our meds? What do we tell our patients getting up fasting? They're not going to take their metformin or their glucophage in the morning before they have it. You go get your blood sugar fasting, and then you can take your eat and take your medications. What do we pick for? Do we want to pick oral diabetic meds for our pregnant mom? No. What do we say about that? Insulin. Insulin for her to control her blood sugar. So here's our FYI. This is us. We're sending somebody or they're preparing for an oral glucose tolerance test. Make sure they try and eat a balanced diet and not a whole lot of carbs and like before you're going. You're gonna fast. You're gonna get a fasting blood sugar. During the time while you're there, they're gonna keep you at LabCorp. They're not gonna let you drink soda or drink anything else that's gonna affect the numbers. You're gonna get your blood glucose every 30 minutes, every 2 hours. And again, after 2 hours, you at least need to be below 200. You're gonna go up because we just gave you a bunch of sugar to drink. But at that 2 hour mark, we want you to at least be below 200. Anything above 200 after 2 hours can indicate diabetes. Here's our A1C. Our target is less than 7. It's just some examples of blood sugar monitoring, and we've all done that hopefully in clinical at this point. Again, we talked about different signs and symptoms. We talked about where we want our fat content to be, what 15 grams of carbs. We talked about tummy up care. What do we tell people? Here's some examples of those 15 grams of carbs. 3 to 4 pieces of hard candy, 3 to 4 sugar tablets, 4 ounces of juice, 4 ounces of regular soda, 8 ounces of milk, 1 tablespoon of sugar, 1 tablespoon of honey. Talk about sugar if you're eating or exercising. There's diabetic ketoacidosis, and we just kind of talk about all this stuff and what our treatment will be. Give IV fluids, get the blood sugar down with giving insulin, monitor the potassium, correct the acid-base balance by giving what bicarb. We just talked about that. That's our treatment. And then we talked about hemophilia the other day. I don't think there's, I'm trying to think if there's anything else on this slide that we need to go over. I just wanted to go back over. Everybody feel like you're okay with sickle cell. You know what that is, how we treat that. I think that's it for this PowerPoint. All right. Okay, so let's take a break and then we'll come back and talk about cystic fibrosis.